Hi there, everybody. Thank you so much for joining us for another educational webinar from Fullscript. For today's session, I'm super excited to introduce you to our guest, Noelle David. Noelle is a pharmacist and a practitioner of functional medicine. She graduated from the College of Pharmacy in St. John's, Newfoundland, and has been very passionate about the prevention and reversal of chronic disease ever since. Noelle is the founder and clinic director of FX Vitality and Functional Medicine in Halifax, in Nova Scotia, and in Oakville, Ontario, where she incorporates her functional medicine training received through the Institute of Functional Medicine. She's a consultant for other practitioners in areas of deprescribing, drug/nutrient depletion and interactions. She is a qualified practitioner of the Bredesen protocol trained under IFM and Dr. Dale Bredesen in the prevention and reversal of cognitive decline. She has received provincial recognition from the government of Nova Scotia on multiple occasions for promotion of healthcare in the community. She also has her own brain health program, BrainWorks by FX Vitality, where she assists clients in improving their cognitive health through a functional medicine approach. With how busy she is, we are very lucky to have Noelle join us for the next hour or so to teach you all about managing a polypharmacy from a functional medicine approach. So without any further delay, I will pass things off to her. Noelle, thank you so much for joining us.
Thank you so much, Cam, for that wonderful intro, and welcome everyone. Thank you for taking your time to attend today. I know you're all very busy, and thanks to Fullscript for hosting this webinar and for shining the light on this important area. These folks at Fullscript are great, and of course they're here with us in Canada, so I'm proud to say that. It's an honor to be here and to be invited to speak about this area of healthcare. This is definitely one topic I feel very passionate about, and it's one of my favorites. My passion as a functional medicine practitioner and pharmacist is to help people feel well. So I have to say that throughout my career as a pharmacist, I've always hoped we would be having this conversation. But it took a while, and for someone like myself who gets an idea and then says, let's do it, let's change the world now, you soon realize that not everyone is on the same page necessarily, and you must wait with patience. But deprescribing is that really a new phenomenon? Well, not really, because somebody once said, drugs don't work in patients who don't take them. But then we have to ask, why don't they take them? So patients have been tapering and stopping their medications, for years, really. The data shows that about 50% of patients take their medications as prescribed. And the reason? Numerous, from adverse events, numerous medications that are already prescribed. And most people don't remember what the physician told them a few minutes after they leave. So it's great, that this area is formalizing and we can help our patients through the process, reduce the polypharmacy, and help them find what works for them. So I'm a licensed pharmacist in 2 Canadian provinces. I'm servicing clients throughout the east coast of the country and through Ontario and beyond. One of the most exciting things happening in my career right now is a new focus on the importance of reducing polypharmacy, and we're having pilot projects in our pharmacies in Canada with the goal of taking people off of their PPIs. So we understand, and I can speak for pharmacy, that there's much more required of us in playing a role as team players in the larger system. And one of the most fulfilling things I've done in pharmacy practice was a recent 19-month pilot project where I collaborated with a physician with the goal of reducing blood sugar, BMI, and blood pressure in our shared group of patients. And this was supported by the Doctors Association, Pharmacists Association, and also our government, our Department of Health. So needless to say, there's a lot of functional medicine food plans in my patients' hands through that pilot project. And the demographic was a lower socioeconomic status, and it was never more exciting to see the faces of those patients when someone spent time caring about their health, not just their drugs or their symptoms, but their overall health. It was wildly successful, and I was really honored to be a part of it. And our Pharmacists Association here in Nova Scotia is one of the most progressive in the country, and so many positive changes being made quickly. And I'm not really here to say one form of practice is better than another. It's how do we heal the patient? So when you ask the patient that question, how do you feel? And is your current treatment working for you? No matter what your practice, whether it's in a clinic or across a pharmacy counter, the answer will tell you how well you're doing in their treatment process. The patients want to be heard. I noticed that I generated much more interest from them in general when you start to speak about lifestyle and not just the medication. So, our system consists of seeing the doctor, getting the expected prescription, and then filling it at the pharmacy. And after that, in many cases, that's about it till the next refill, followed by increasing dose of medication, adding on new medications, and, a lot of cases losing vitality and health as the weeks go by. So, however, I'm so happy to say that this is changing with expanded scopes and opportunities to sit with patients and consult and improve health. So one thing I'd like to say up front is that when deciding to taper or discontinue medication, you had to do your due diligence. If there's any uncertainty about patient safety, you don't touch the medication. I'm saying this thinking of all the disciplines that may be listening and different scopes of practice and different situations. So as we go through, we'll be talking more about this. So as you notice in my header page right here, medication taken by the patient is not one-sided. There's another party or parties involved, hence the spoon-fed patient. So we have the responsibility to understand the outcomes of our role in administering medications. And this philosophy of deprescribing fits so well from a functional medicine lens as we look at the whole person. So this has the potential to tremendously reduce chronic disease and costs to the systems by millions and billions. And who wouldn't want that? So, and this is coming more to the forefront, I believe. It's starting to hold in mainstream medicine to take hold, but it's just, they're doing it in just a limited way currently. And because there's not a lot of research done on specific meds and say their reduction, there's a limited resources for guidance. However, because of the huge costs of chronic disease, increasing numbers of people reaching senior years, and increased consumer awareness of the facts, there's a driving force for change. So let's dive in. The first few minutes are a little bit about how we got here. I know many of you may be familiar with this, but I like to talk about it because to drive home the message that this is still where we currently sit in our system, and the magnitude of the issues as it exists for our healthcare system today, as far as cost to society as a whole, and to all of us involved, not least of all the patient. So I do have a disclaimer here. Let's get this up for you here. Just one sec. So deprescribing and tapering of medication is an extremely individualized process. The following presentation gives general guidance when it comes specifically to the actual tapering and discontinuation of specified meds, but is in no means meant to replace your insight and due diligence when consulting with your patients, nor meant to form a blanket policy. So just keep that in mind. We're very individual and this has to be done this way. So learning objectives, where are we currently? How did we get here? Deprescribing in conventional terms, and then through the lens of functional medicine. General direction and guidance on the initiation and tapering, and considerations and cautions, and then some case examples. And this is what I like to say as a pharmacist. Deprescribing can be one of the most fulfilling things you can do over the course of your career. And most people, if given the chance and support, would prefer not to take medications. And to me, as a pharmacist for many years, and now a functional medicine practitioner as well, deprescribing represents freedom and a brand new focus in guiding patients to true wellness. So here we have statistics from 2018 showing the massive amount of money being spent, $1 trillion US for the first time. North America is responsible for the largest portion of these revenues due to the leading role of the pharmaceutical industry. And based on sales, New York City based Pfizer is the world's largest pharmaceutical company. 2017, some 52 billion US dollars in pure pharmaceutical sales. And here we have Humira, the very potent drug used for many autoimmune disorders. So from 2010 to 2018, growing almost 4 times, with a big amount, but not all, sold in the US. So here we are again, Humira, an anti-inflammatory, generated over 18 billion in 2017. Oncologics, so the cancer drugs, 81 billion. And this is the one that's staggering as well. It never ceases to amaze me. The diabetes drugs and devices have become one of the fastest growing parts of the US healthcare industry, and simultaneously one of the largest segments of the healthcare ad marketplace. And how big? About 176 billion in direct medical costs associated with diabetes. So we all know that this is something that we can really play a role in and help reduce. So we can see here the graph for diabetes med spending. You can see the increase from 2012 to 2015 and 117% increase from 2014 to 2015. And then we have the top 10 most advertised diabetes medications. So according to Kantar, a market research company, direct-to-consumer pharma spending jumped 11% to 2 billion in 2018. And this is all in these references that are here. Pfizer was by far the top spending direct-to-consumer advertiser, with things like Lyrica, so for fibromyalgia, Eliquis, atrial fib, blood thinner, and Chantix to quit smoking. So we can see the pattern here. And what are all these conditions? We deal with them all the time in functional medicine. The ultimate goal of the patient is to feel the best they can. So they will seek out practitioners to help them do this, whether it be their physician, their pharmacist, functional medicine practitioner, and they'll continue till they find what they're looking for. I see this all the time. If they still don't feel, or if someone doesn't still feel better, they usually don't accept this and they look for better in many cases. So we need to keep up with this, and we need to do what's right for the patient as well. You know, the focus here is on the US direct-to-consumer advertising, but we're not immune in Canada. As well, I don't like to just focus on the direct-to-consumer adverts, as there are so many other factors at play, and so just to look at one aspect would be missing the larger picture. So just a little bit about how we got here. A long time ago, there was technical changes of importance to pharmaceutical discovery. 20th century progressed, as it progressed, it brought in more appreciation by the general public and politicians, prompting governments to develop mechanisms to provide support for research. And this is what they say, thus the symbiotic relationship between large public institutions carrying out the research and the private companies making use of the new knowledge to develop and produce new pharmaceuticals begins. So here we can see how the public-private relationship between research and pharmaceutical companies begins. And this is a little bit more. So the first point here, each year, the National Institutes of Health budget provides less money to fund clinical trials. Because of this, the drug companies pay for and run the majority of these trials. I won't read through everything here, but I'm sure you get the gist of what this is saying. So this could mean drug companies greatly influence the majority of medical information provided to the public. So this really makes a statement of our current system. And when we look at the amount of medication someone is on, it gives us a little bit more perspective to the process they walk through to actually get here. And this is a Canadian study, so a +1 study that was in the Canadian Medical Association Journal, and it references this study. So pharma influence is widespread at medical schools. And what I find interesting in this article, it points out that conflict of interest would be gifts, where drug companies provide pens and prescription pads or lunches, while a more complex conflict of interest would be ghostwriting, where faculty members sign on as authors of studies conducted and written by pharmaceutical companies. And like they say here in this point, that the conflicts of interest are systemic. And they also point out that such issues will only become more prevalent as medicine is increasingly corporatized. This is what they refer to in the article. Meanwhile, government grants to medical schools may require industry partnerships. So I'd like to point out that even if there was a system in where there was no industry influence, which would be nearly impossible, there's a lot more at play to actually increase health. And this has to come from every player in the system, with ultimately the patient's best interest at hand. And it comes especially with education of your patient, working with you and their team. So deprescribing in mainstream terms. So this is, when I say mainstream, I'm referring to how most people see it currently. So deprescribing is the process of intentionally stopping a medication or reducing its dose to improve the person's health or reduce the risk of adverse side effects. So deprescribing is a good part of good prescribing, backing off when doses are too high or stopping medications that are no longer needed. And we'll find out in a minute why this is so timely and flowing into mainstream. Concentration is largely focused on the elderly with limited life expectancy. So what we hear a lot is when we view deprescribing this way and when we search it online, the reference is made to elderly and the risk of falls, for example, getting off of diazepam and lorazepam and the sleeping pills. Or for example, when a patient doesn't have that much longer to live. So basically they say you can stop a statin for cholesterol when someone is expected to die within 5 years, or stop a bisphosphonate, drugs that are supposed to reduce the decrease of bone mass and osteoporosis. You can stop these in patients expected to die in less than 2 years. So it sounds pretty depressing, but when we look at it from a functional medicine perspective, increasing health and vitality to prolong life is where we're focused. So here's where there's a different focus and just a little different lens. And here's why it's coming to mainstream. I mean, it's becoming a critical situation. We can see the seriousness as far as costs and human life goes. So 30%, and that's probably a lower number, of older adults in the United States are taking 5 or more drugs simultaneously. And drug-related morbidity in the US, adverse drug reactions, and serious among the top 10 causes of death, and expensive, with associated annual cost at 30 to 180 billion US dollars. So you can see something needs to be done here, and this is why one of the big reasons why polypharmacy and deprescribing is coming to the forefront. So this is where functional medicine excels in decreasing the costs and saving millions. And here we have some very alarming stats. So a study from Quinn and Shaw from 2017, where they examined a data set of prescription drug claims over 7 years of 150 million patients. And this is their findings. Polypharmacy is being driven by high rates of comorbidity, and it's causing the comorbidity. So that's a very vicious cycle, and it is very disturbing. So we can see how deprescribing can certainly fit in here and help all around cost-wise, and most importantly, to help people stay out of the doctor's offices and the hospitals. So right here, so through the functional medicine lens, as we all know, or a lot of people that are tuning in here are in tune with this, we look to get to the root of the issue. Our patients are many times complex cases. They still don't have answers. Age doesn't matter. A great number of our patients want to decrease the meds and are looking for answers they have not gotten. Our goal is to dive deep to see what factors are inhibiting optimal metabolic function. And this many times can be medication related and may require decreasing or discontinuing. So I even have patients who have been to various integrative practitioners as well, like many different practitioners, but unfortunately, they still haven't found their answer and they still have more digging to do. And they end up looking for functional medicine specifically. So I've had a lot of people say that to me. So deprescribing antidepressants is serotonin, depression is serotonin deficiency. So I guess we all have an answer for that. So where is much of our serotonin made? The approach to tapering is very much an individual thing. After a thorough history and agreement to taper the medication, these meds are usually gradually decreased over anywhere from a few weeks to a few months, and for some even longer, to minimize the harsh withdrawal symptoms. And this is a little something here that I find interesting. This is potentially due to serotonin transporters and how it affects receptors, genetic expression, neuron growth, as well as HPA dysfunction. So this is how complex it is. According to a study, I don't have this reference there, but if you wanted it, I can pass it on. The Salk Institute published in Molecular Psychiatry this year. It's now thought that neuron growth and gene expression may be related to why some depressed individuals do not respond to SSRIs. And they basically found that SSRI non-responders had increased receptors for serotonin, which made the neurons hyperactive in response to serotonin. So unraveling the puzzle of SSRI resistance has been challenging because listen to this, it requires studying the 300,000 neurons that use the neurotransmitter serotonin for communication within a brain of 100 billion. So total neurons. So here we can see the complexity of this mechanism and how chasing it down is virtually impossible. While the time spent might be important trying to figure it out, by using a systems biology approach, we can help get to the root cause. And you often hear someone say that this medication is the only thing that's worked for me, but that may be so, but when you look a bit deeper at maybe genetics, SNPs, nutritional status, for example, you may find other reasons for symptoms that present as mood disorders. So when we look a bit deeper, we can certainly find more in many cases. So withdrawal symptoms are real, and I just want to focus a little bit on this in the next couple of slides because it is downplayed quite a bit as far as SSRIs go. So the mnemonic finish, flu-like symptoms, insomnia, nausea, imbalance, hyperarousal, sensory disturbances as well. And I have a note down here, we'll talk about this a bit more. Do not confuse withdrawal with the body's need for more drug. So you need to educate the patient on what to expect. So we often hear that benzos, which they are really hard to come off of, but the newer antidepressants are not so bad. Just taper for a couple of weeks and then you're fine. But surprisingly, and maybe it's not surprising to a lot of us, but this isn't the case. More studies and patient experience are showing this is not the case when it comes to these SSRIs. The picture on the slide is from an article from risk.org, and they call it Descent to Hell, where a person is describing her experience with antidepressants, trying to come off of them, and her many unsuccessful attempts and a nightmarish experience. Risk.org is a Canadian-based organization led by Dr. David Healy, an internationally respected psychiatrist and scientist. And their mission is making medicines safer for all of us. And we'll talk, as I said, a little bit more about the need. We have to educate the patients on what to expect as far as the withdrawal symptoms. And tapering, this is just another study that was done. So these authors in their paper that was in the Lancet Psychiatry, they argued that any responsible withdrawal regimen should have the patient tapering off over months or even years, and not over the 4 weeks that are in the guidelines. Although the withdrawal syndrome can be differentiated from recurrence of the underlying disorder, it might also be mistaken for recurrence and thus leading to long-term unnecessary medications. This is what I find noteworthy here. It might be also mistaken for recurrence, leading to that long-term unnecessary med prescription. And I see this quite often when the patient has no support. The only thing they get is that add-on or a new antidepressant to help the symptoms of the disease. And when we look deeper, we can help overcome this. But just by treating the symptoms, usually we're missing a lot for sure. And here it is again. This is just another study that was done. They basically, this is from the NHS, and it's a British study from the British Medical Journal. The NHS prescribed a record number of antidepressants last year. Data show that almost 71 million prescriptions for antidepressants were given out in England in 2018, compared with 36 million in 2008. And from the reference here, these two researchers are saying that the UK's and the American Psychiatric Association's guidelines state that withdrawal reactions from antidepressants are self-limiting. That is, they resolve within 1 to 2 weeks. And they show that this is not the case. So they say current UK and USA guidelines underestimate the severity and duration and of withdrawal with significant clinical implications. And here again is part of, it's another study that was done. We recommend that UK and USA guidelines on antidepressant be urgently updated, as they're clearly at variance with the evidence, and probably leading to the widespread misdiagnosing of withdrawal, the consequent lengthening of antidepressant use, and the much unnecessary prescribing and higher rates of prescriptions. So we recommend that prescribers fully inform patients about the possibility of withdrawal effects. So practical tips, some practical tips when tapering. So use a reputable compounding pharmacy if needed to decrease doses very gradually when you need to do this while supporting your patient. Do your functional medicine history and workup. Uncover the other potential imbalances. It's usually never just depression without other comorbidities. If a number of meds need to be tapered down, usually begin with one only. Support one's own neurotransmitter production, ensure methylation is optimal. So most times we know that there are many other things at play, and not just the SSRI or the depression. And most of the serotonin we know is made in the gut, so look there. Many times we'll find issues such as, acid blocker use, PPIs, SIBO, SIFO, dysbiosis, infections. You may be told at first very little by the patient, but when you start to dig and peel back the layers, you'll be amazed at what you find. If a number of meds need to be tapered down, we say to start with one to ensure that if there's issues, you know which med is contributing to it. And here you can also measure, as I mentioned, if you have access to labs or whatever your scope may be, or you can work with the team, just to measure and then supplement accordingly to assist the body's own metabolic system to optimize it from inside out. So I'd like to just do a little poll here. I just need to get my screen working here. Sorry about that. I think I went out of the poll and just hang on 1 second. Yeah. So I just, oh, sorry. So what percentage of your patients do you see in polypharmacy in? 3 or more medications. So select one of the following. So 0 to 25%, 25 to 50, or over 50%. Wow, excellent. Wow, so we've got quite a few then, more than what I actually thought. Not that it's uncommon. Okay, so we're in the 25 to 50% for the most part. Okay, so and then there's just so one other question. Let's just see. Does dealing with polypharmacy affect the time it takes for you to reach your desired outcomes with your patients? So not at all, rarely, sometimes greatly and extremely affects. Wow, yeah. Yeah, so this is really showing me something here for sure. Yeah, so most people are saying greatly affects. Yeah. So yeah, so this is something that, is playing a big role in, a lot of our patients' therapeutic plans and, their outcomes as well. And follow-up is so important. So, so we have a case here. So Jane, a female patient, 54 years old, current meds, buspirone 20 milligrams twice daily for 1 year for anxiety, lorazepam 1 milligram at bedtime, 5 years, escitalopram 10 taken for 2 years for anxiety, depression, before switching from paroxetine for 2 years, Premarin, the horse estrogen, medroxyprogesterone synthetic, progestin, Synthroid 150, the T4. So is there polypharmacy here? This is not uncommon. I see this all the time, and there's more add-on and add-on. So medical history symptoms, depression, anxiety, brain fog, IBS, hot flashes, fatigue, problems losing weight. And here we have tries to eat healthy, but no guidance on choices and too busy, like a lot of people. So as I said, this is not uncommon. I see this so often. You see a bag of medications, plus, not to mention, a bag of supplements taken at once. So here you need to focus on the drug supplement interaction and what you can reduce or is not helping. So I also see many patients on many supplements, but they still don't have the lifestyle piece figured out. And they look to you as their health is still not optimal. And as well, they haven't been tested for any nutrient deficiencies, the B vitamins, for example, or other areas we could look at. So for Jane, what jumps out at you? Any thoughts? It seems that she's not having the success intended with the SSRI, the anti-anxiety med, or the sleeping pill, according to the symptoms that she still has. As well, she's going through or has gone through menopause and is treated with the synthetic hormones, and also for thyroid, she's treated with just the inactive T4. So we don't know if she's converting to the T3 or even what her labs are here. And, from the Women's Health Initiative a few years ago, showed most of the problem was with I call it the horse estrogen, which is mostly the estrone, not the estradiol, and has the potential to cause a lot of issues with the synthetic progestin. So she's likely currently not being treated optimally, considering other options that are out there. So for our focus here, we're just going to discuss the meds for this time for the mood and sleep. So we can go into that for time. And what else jumps out here? Obviously, the BMI, body fat percentage. So her diet isn't great. So where to start with Jane? So she tried to stop the buspirone and venlafaxine, quote, cold turkey a year ago and became severely anxious, felt horrible, and restarted because she needs them, quote, for anxiety, depression. Establish with the patient the reason. So what we did was establish the reason, or what you can do for each drug. Is there a known benefit to the patient? Past diagnoses, thorough history through a functional medicine lens. So we determined with the patient that yes, we can deprescribe, and we started with the buspirone because it had no benefit, and when added to the regimen, it in fact seemed to make her more jittery. So we started with that. This didn't happen overnight, and it won't be fixed overnight. So it's baby steps. We do a review of all the meds, and like I just said, and consult with her for the whole history. And the healthcare practitioner is important here, and the team. So it's important to also, work with the physician. Obviously, if the physician is a player and is understanding what the patient is looking for here, the patient is the main player here, and they need to be on board with everything. Obviously, it's an individualized process. So we can cause issues if we don't proceed with caution. So I'm not endorsing that anyone listening just stop all their meds, But what we're finding is that one can actually be added to boost the effects of the other, or to help with side effects of another. So here's where we started with the buspirone because it had no benefit. And here's what we did. So we decreased it to 15 milligram twice a day for 2 weeks, then 10 milligram twice a day for 2 weeks, After 4 days, she became anxious and was not able to really function socially. So we had to increase it back up a little bit. And then we gave a bit of GABA support, some theanine, B6, magnesium, glycinate. And it has a slow, it has a short half-life, so you need to go slow. But anyway, besides that, the effects on the receptors make it that you have to go slower and taper slowly anyway. And you also need to be aware of drug nutrient depletions like calcium, potentially melatonin, with the benzos like lorazepam. So it's all very slow, and you start low. So always check with someone who works in this area, as a thorough history will have to be looked at. She did well with that dose, and we were able to decrease by 2.5 milligrams twice a day every 2 weeks till she was off of it. Also, cognitive behavior therapy, I just want to mention this, for insomnia has a lot of studies, and it's shown to work quite well. And there's a great resource that's at the end of the slide deck, sleepwell.ca. They have a lot of excellent information in there for the patient and the practitioner, and there's a lot of detailed information in there. So their recommendation is to start the CBTI, the cognitive therapy, about 2 weeks after taper starts. And again, all this would depend on how long someone took the med and how they're doing with the symptoms while tapering, and how they're supported in other areas such as nutrition, relationships. So all this makes a big difference. And the lorazepam, after a couple of weeks, we started the lorazepam taper, 0.5 daily for 3 weeks. There was no issues, 0.25 daily, and then down to 0.125. It was compounded each night for 3 weeks, and then one every second day, because then this dose every second day, because of the longer half-life, it still wasn't out of the system, for 2 weeks, and then every 3 days. So after about 4 days, she couldn't sleep. So she was interested to use some herbal teas. So we used some with passion flower, lemon balm, chamomile, and we went slower. We went back up a little bit for 10 days and then back down to every 3 days. We supported sleep as well with melatonin, early morning sunlight, and to balance the circadian rhythm. So these can be very hard to come off of, potentially months and sometimes longer, and depending on the support and the situation. And, you know, just a note of interest, 90% of studies are only done for 2 weeks long on sleeping pills. There's no evidence to use them long-term whatsoever. So next up is the escitalopram, right? And I guess a lot of people might think that's the easiest, but it was actually a little bit more difficult. So basically, I always say, so after a closer look, I like you even less. So the patient had tried this one many times with no success. Everything worked till she split the tablet down to 5 milligrams every 2 days. Then she ended up having extreme dizziness, fatigue, and anxiety. So we ended up having to use compounded liquid and decrease by 1 milligram every 4 weeks. So it was slow. And then she said after she was able to come off of it, that it felt like a curtain was lifted off of me. I could think again and function normally. So, you know, wow, like that is just so rewarding to hear. And here we have again the link for sleepwell.ca. You know, sleeping pills, as it says, are supposed to be used short term. They don't work much longer than that. And then you need to keep increasing the dose because of the dependence, and becomes a vicious cycle. The other thing, so this gets into a little bit of the support in the 5-HTP. So the other thing we can do is support the serotonin. This is, you know, you need to be cautious. Everybody has different ideas on how to do this, or if to do this or not. So if you're monitoring and following up and assessing interactions with all the supplements, and knowing all the supplements that they're on, that's important, because sometimes you don't really know everything until they actually maybe bring them in on the second visit. And so you'll hear some people say you can't do this, you can't combine it. Many people do, and they find it quite beneficial. I don't recommend unless you're monitoring and there's proper follow-up. And as well, something to think about, the serotonin may already be reduced from the downregulation of the receptors from the SSRI. So this references a study that was done in mice in neuropsychopharmacology on treatment-resistant depression, and they concluded that an SR formulation of the 5-HTP will substantially improve the therapeutic properties of 5-HTP because of the limits of the short half-life of the IR formulation. They just say it works better. That's what they found. And the benefits is that it all doesn't get dumped at once into the gut, and because it can cause some gut issues as well. Instead, it allows time for it to convert in the brain. And they say you may be able to take a little less, as the IR only has a 90-minute half-life, so you need to take it a number of times during the day. And they believe that the probability of a 5-HTP SR will be safe and effective in treatment-resistant depression. So that's something to keep in mind if you want to get a formulation that's SR. There are some, I don't know how many. I have come across a couple, but I don't think there's many of the SR. And also we like to tell people with the 5-HTP, sometimes it's better to take it earlier in the day because it can increase cortisol in some. So the longer acting formulation may help there. So tryptophan, so this is the other, with tryptophan, a lot of people love it for sleep, and it converts to 5-HTP. Then there is the caution if there's high inflammation. I don't know how many people are using organic acid testing, but it can go down the indole-amine dioxygenase pathway, and it can metabolize to the pro-inflammatory compounds instead of serotonin. So if the patient has a lot of high inflammation happening, it's just something to keep in mind. So if you do an organic acid test, and this can be complex if they're already on SSRIs. So and if you see the metabolite, the 5-hydroxyindole acetate, that's the serotonin metabolite. If the levels are really high or really low, they could be potentially burning through serotonin. And if they're inflamed, more of the kynurenate and quinolinate metabolites will happen through the tryptophan metabolism. So then some people, because of this, will give the 5-HTP. It gets a little complicated as well if you're on an SSRI. So it can be a little complex and may not always be feasible. So I always say start low and go slow, if you feel, especially if there's any concern at all. So serotonin syndrome is mentioned here, and I just like to mention something about that. Just keep it in mind. A study from the Cleveland Clinic, Journal of Medicine, 2016, they say mild serotonin syndrome is easily overlooked by practitioners and physicians and underreported. Every patient with mild serotonin syndrome is a potential candidate for developing life-threatening. But I think mostly what they're talking about here are the combos of pharmaceuticals, which we see people on many times as well. So the need for diligence just goes without saying. They say things like tremor, hypertonia, hyperreflexia, for example, if you see that, to look for mild serotonin syndrome. In addition, every patient on any serotonergic drug should be examined for the presence of this before escalating a dose. That's just something to keep in mind, obviously, when you're taking them off of an SSRI and using a small amount of the 5-HTP. You probably won't run into that issue, but it's something to just ensure that we're doing no harm. Here we can see the potential nutrient deficiencies that could be presenting when we look at what we call depression. There's so much here in functional medicine to look at. So including the genetic, epigenetic areas, we can look at methylation to ensure B12 and folate are optimal. Do they have MTHFR SNPs if you do their genetics? Are they methylating, as this may be affecting neurotransmitter production? And the VDR SNPs as well, which is, helps or causes the decreased activity of vitamin D in the body. Nutrient, vitamin deficiencies. If you can't do a functional medicine specialty test, then the conventional homocysteine, CBC, B12, RBC folate, vitamin D, etc. So those things would be very helpful. And of course, the food. So, always ensure there's a whole foods, plant-based diet to ensure that that nutrition is coming in. And if we want to dig a bit deeper, we can look at the gut health and food sensitivities. But to start, we would start with the standard elimination, of the major inflammatory foods. So here is one confused yet? Coronary artery disease, changes in the recommendations again. So this uncertainty is reflected in international guidelines where, for example, aspirin is not recommended in European guidelines for primary atherosclerotic CVD prevention, but is recommended in prior US guidelines. And adding to this controversy are more recently conducted primary prevention trials that, in contrast to the older ones, have shown less benefit of prophylactic aspirin. So there's lots of confusion here, and there's no wonder. So ASA was just unrecommended again for primary prevention. So these guidelines have changed quite a bit over the last few years. There's a lot of back and forth. Now they're saying that the bleeding risk outweighs any benefits in primary prevention. So just about everyone I see 50 plus in a pharmacy environment is on 81 milligram ASA. It's as though it's the drug of choice. So one may question then, over all these years, should they have been taking it or not? And, you always get that question as well. Should I or shouldn't I? It is a bit confusing. I actually just had someone recently ask me for the 325 milligram enteric-coated aspirin, and I haven't seen that for years. So when I asked why they took them, they said for prevention of heart disease. And then when I asked how long, they said for years, and there's no intervention or follow-up. And as well, there was no history of previous heart disease. So my first thought was that there could be a high potential risk of a bleed. So, and they should speak with their doctor. So because of this just little intervention with me, they decided to speak with their doctor regarding if he really needed it, and even if he really needed the 81. So this is a little bit more about how little things and just a little step can educate a patient to providing them with more knowledge, and knowledge is power. So another case here, we have John, 64-year-old, diagnosis, diabetes type 2, hypertension, neuropathy and tingling in extremities, pain and fatigue. So current meds, insulin, metformin, Victoza, amlodipine, metoprolol, hydrochlorothiazide, the diuretic, ibuprofen, the NSAID, 400 once a day average, and our purple pill, our Nexium. And the A1C is considered good now. So with all these medications, the A1C is still 6.9. And guidelines say A1C less than 1.5% above individualized target, use lifestyle modification with or without metformin for 2 to 3 months, and then reassess. And then step 2, it says add any other drug or insulin, so pick one. So think about this, how did we get to this with John? I have patients say, this is true, I actually have patients say to me, my doctor cannot put me on meds yet, but when I get to the hemoglobin A1C of 6.5, then they can put me on meds. I'm just waiting to get there. I have actually had someone say that to me. So, lifestyle, even though it's first line, according to the guidelines, is not often given the attention that it should be given. So here we try to unwind, start backwards as to why he came to be on each med as best we can. So we start with functional medicine, food, lifestyle. So when we did this dropped the blood sugar down, and he could decrease, or he had to stop the insulin because you end up going too low, and that can be critical. But here you need to monitor and monitor as well. I keep saying that. So, and as well to mention again, the A1C less than 1.5%. So then when we use lifestyle modifications for 2 or 3 months and then start the metformin. So the problem is lifestyle never gets as much quality discussion, as it's much easier and faster to say after 2 to 3 months when the blood sugar is still high, here's the metformin, and then it goes from there. Then as second choice, pick one. So this is our road to polypharmacy. So to note, I just want to let people know this, there was no history here of heart disease, and these meds had accumulated over time for blood pressure. In consult, this was done in consult with the physician who was fully on board. So we can look a little bit ahead here, a couple of slides, to just look at nutrient deficiencies, to see as well if there's any meds potentially causing some of the symptoms and possible nutrient deficiencies. So B12, metformin decreases this, so that could be contributing to the neuropathy on top of the blood sugars contributing to it. So we took him off of the cyanocobalamin he was on, and we did a sublingual methylcobalamin with some active B vitamins. We can see here from this chart that there's quite a few possibilities of nutrient depletion with the different meds that he's on. So we'll just go back. So in consult with him, he wanted to start with the diuretic. He was having some increased urination, and he was concerned that this was related to the diuretic. So there could have been other reasons for this, but there was no reason to not taper it. So that's what we did. As well, his meds, the NSAIDs, so the ibuprofen combo with the diuretic can potentially affect kidneys. He's diabetic on top of that, so more risk for kidney damage. So there's so many factors at play here. So we lowered the hydrochlorothiazide down to half. It has a relatively long half-life, so he did well with this dose, and then every second day for a week. So there can be a chance of rebound fluid retention, but if you balance the electrolytes, ensuring there's a good balance of potassium as well, which then positively affects blood pressure too, and not to have too much of just processed sodium in the diet as well. So there is a precaution here though, if someone is on meds that can increase potassium. So you need to be careful of that. And on an aside, an option here, if needed, for the short term, would be to use herbal diuretics such as dandelion, if necessary, but there is a caution with diabetic meds, as that can increase the risk of low blood sugar, and for blood pressure as well. Hawthorn is used, and a lot of people find they have good results with that, but you just need to monitor. When you discontinue the thiazide and balance the electrolytes, the issue of fluid retention would potentially improve. So the beta blocker, that could be contributing to fatigue. I think I'm really getting close to my hour here. So if anyone needs to jump off, this will be archived. So I just want to let you know, sorry about that, guys, but I didn't realize this was I'm going over a bit. So this could be contributing to fatigue, exercise intolerance, decrease gradual. We went from 25 twice a day for 10 days, then down to 12 and a half twice a day for a week, and then we stopped. So caution, you don't discontinue this if there's uncontrolled hypertension, if someone cannot follow lifestyle, or they can't self-monitor, if there's a history of an MI and myocardial infarction, or if it's not in your scope of practice, you need to use a team or refer. If there's any chest pain, pounding heart, anything like that, the recommendation is to go back to approximately 75% of the previous tolerated dose. And before discontinuing these, it's important to ensure there's no other conditions happening, like I just mentioned, and you need to monitor the blood pressure for a few months after. Just to mention quickly, the blood pressure monitoring, some doctors' offices have a blood pressure monitor where they monitor over 6 and take an average, and they leave the person alone in the room so that there's no risk of the white coat, because with the white coat, the blood pressure is not always accurate, and it's probably one of the least accurate ways now we know to measure the blood pressure. So Victoza, this is just from the website. This is right from the website of the manufacturer about the serious side effects. And so I always ask, is this a choice in your diabetes regimen? So a lot of these warnings show up post-market or after its release when reports start coming in. So just to know how this works, it was shown to be due to glucose-dependent insulin secretion, slowing of gastric emptying, and increased beta cell mass. So this medication causes more insulin to be released and beta cell enlargement. There's pancreatitis that is possible as well. Common GI effects because it slows down the gut. So we decreased and went off of that. And just another quick study. These are on berberine here. So they basically showed that berberine treatment was associated with a better reduction of fasting blood sugar, postprandial, and hemoglobin A1C. And the controls that they use is interesting here. The controls that they actually used were hypoglycemic agents or insulin. So berberine in this study came out better. And this is just another one. It was a meta-analysis from the Journal of Ethnopharmacology, 27 randomized trials in over 2,500 patients. And they basically measured berberine against many like lifestyle. They did lipid lowering drugs, they did blood pressure lowering drugs, and they basically showed that the berberine came out on top, basically compared with other first-line medicine and treatment. Berberine was a good alternative option. It had comparable therapeutic effect on type 2 hyperlipidemia and hypertension with no serious side effect. So some people say over the long term it may cause potential microbiome effects. So you can always supplement with probiotics, fermented foods, and depending on who you read, there's more and more research showing now that berberine can have positive effects on the microbiome. However, some still recommend to use caution here for that. So the International Diabetes Federation, metabolic syndrome, waist circumference is one independent risk factor for metabolic syndrome, and this is becoming, a big issue for so many people. And here's a very inexpensive tool for measuring the measuring tape for measuring your risk of one of the factors for metabolic syndrome. And here's how to do it correctly and how not to do it. And it reminds us that lifestyle recommendations in the guidelines as first line should not be ignored. So we're back here, so John's, we look at John's meds, his metoprolol, the beta blocker, we can see CoQ10, melatonin, depletion, possibly, the thiazide CoQ10, the metformin CoQ10, folic acid, B12. The Nexium is doing a big job on his B12, magnesium, calcium, and others. And his symptoms of pain and fatigue, could this be mitochondrial dysfunction from the reduced CoQ10? The neuropathy and tingling, possible B12 from B12 deficiency. So a very helpful thing we can do for John is to deprescribe. So monitor the electrolytes depending on your scope of practice. Teamwork here is beneficial if not essential, as is the health coach. So the health coach, actually, someone to follow up with that person and give them the support that they need is really, is what really matters, because that is so much needed here, and the practitioner many times does not have the time to do that on a weekly basis or on a every so many day basis. So most importantly, to get the patient support, guidance, and refer if needed. Monitor the blood pressure regularly, instruct the patient to report any side effects immediately, hypoglycemia, and then it's what we did with the amlodipine. So here we have the PPIs. So we reduced the ibuprofen. So it was ibuprofen we were using. We added some non-pharm options, optimized the omega-3 and the vitamin D. So remember, the NSAID or the ibuprofen can have negative effects on the blood pressure, the heart, and the gut. So many things that was happening to John is another example of possible drug-induced harm or iatrogenic effects. So when we look back at his history, we found the ibuprofen and the PPI came first about 15 years prior. So we can see here how these things can be continued if no one intervenes. Then came the blood pressure, then came the blood sugar increases. So this is a typical case of many likely drug-induced issues leading to polypharmacy, along with the poor diet and lifestyle, which leads us here to deprescribing. So I just want to ask this: if there's no intervention, where do you think John would have likely ended up? Like many others, continuous worsening of drug-induced nutrient deficiencies, increased dosages, numbers of meds, complications of high blood sugar, kidney disease, amputations, hospitalizations, How much does this cost the system and the patients? Billions. Some people actually call it an economic tsunami. And what can we all do about it? Thankfully, a lot. And remember, most patients, if given the chance, would rather take less meds. So it comes to education and support. So we help them decrease the NSAID with the omegas. Some people do get a bit of an upset stomach with the curcumin, so just be aware of this. It can take it with good fats if that's a problem. So we'll just move on to the next one. This is how I got into functional medicine. It was a PPI story. So I had so many GI issues that I couldn't work for a whole year. This cost me time and energy and cost the system money. So I was given a PPI and told by a GI specialist that I would be on it for the rest of my life. And I knew enough that I just thought, I don't think so. They did colonoscopies, gastroscopies, and nothing showed. And then you know what happens, right? It's all in your mind, right? So then I decided to visit an integrative team outside in another province in Ontario. And I learned what I was eating, stress, and other factors were playing such a big role. And what I actually had was SIBO, and I was reacting to a big 8 sensitivity. But I was told it was IBS, right? The rest is history. So, that's how I looked to another option and found functional medicine. I haven't really looked back since. So how can you, right? So there was just a study on the attitudes and beliefs of doctors from the proceedings of Singapore Healthcare. And one of the aims of the study was to explore the attitudes and beliefs of the doctors in deprescribing. So change is the biggest problem here, and a willingness to stop medications prescribed by another doctor. So we love change in functional medicine. This happens to us all the time, and the patients we see are not the status quo for most practitioners. So the study conclusion, basically many older patients, this is key. So many older patients have shown their willingness to reduce one or more of their meds if their doctor said it was possible. So healthcare providers should be proactive in discussing and evaluating potentially inappropriate medication. So part of good prescribing is knowing when to discontinue the medications. So clinical pearls, this is, I won't go through the whole thing, but I can mention, remember always lifestyle is first in the guidelines, use it, fine tune and balance. Remember, the meds were prescribed in the first place to treat the symptoms of imbalance, not to realign and rebalance the whole system. So there's a lot of precautions here, things to watch out for, things that when you should not deprescribe. Cholinesterase inhibitors, that's important if someone has a dementia and they're on Aricept and you're trying to help them. Many times it's not appropriate to taper, so you may have to wait. Sometimes the Aricept can actually end up increasing cholinesterase. So if you abruptly stop the drug, the patient can potentially deteriorate faster as the remaining acetylcholine, our important memory neurotransmitter, is broken down faster. So here's a few more things just to watch for monitoring documentation. Of follow-up liability issues are reduced with patient, health coach, team, and the physician as well if possible, and family all working together. It's important to educate on reasonable expectations with importance of lifestyle. And this is from the Canadian Pharmacist Letter, The Art of Deprescribing. Do the brown bag review, stop one at a time, taper, and monitor for symptoms. So time is one of the biggest constraints. So those of us in consulting practices have more time. That's why we're doing this. And we know in order to really get to the root cause, time needs to be spent. So this is directly from Pharmacist Letter. Pharmacists are actually trained and given the tools to do this from one of the top monthly educational journals for the profession. The reason it's not used as often is because time. So depending on your type of practice and your location, and this is for pharmacy, from chains to compounding to consulting practices, your amount of time, this luxury we call time, is quite varied. So many people just start with the basics, remember the 80-20 rule, and go from there. And this is just a little slide here about the business of autoimmune disease, and I love the European Parliament's committee. So is it? a business? What is it? The European Parliament's Committee on Environment held a workshop called Autoimmune Diseases, Modern Diseases. And the professor there highlighted several environmental factors, from pathogens to nutrients, that breach the tight junction and cause the, what we know as leaky gut. If the adverse effects outweigh the advantageous ones, this could be a step toward the development of an autoimmune disease. So here's some useful resources. And I apologize again for going over. Here is my my contact email and my website. And we have a program for practitioners focusing on polypharmacy and deprescribing that you can find under our practitioner section. And feel free, please, to contact me with any questions or extra info. And your patients can also use it for more info on counseling and polypharmacy in collaboration with you. Our focus is to help assist you and your patients and to adjust or modify their protocols, depending on their goals. And we just find a great empowerment is achieved here. So that's it, everybody. I don't know if there was any questions here. I'll just take a look. See, I don't see any questions. So I guess that's it. If you have any questions, you can send them in to Fullscript and I can answer them for you. So thank you, everybody.